What is going on, everybody? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my EMS, EMT, Paramedics playlist. In previous videos, we talked about how to assess a patient in an emergency condition. We talked about the vital signs, which are for the temperature, the pulse, the blood pressure, and the respiratory rate. As for today, we shall talk about the airway, how to assess the airway, how to secure the airway, and the difference between nasopharyngeal and oropharyngeal airway. Click the like button, click the subscribe button, and let's get started. This is my EMS, EMT, Paramedics playlist. Please watch these videos in order for maximum understanding and retention, not to be confused with your patient's urinary retention. Today we'll talk about airway versus breathing versus ventilation versus oxygenation. We'll talk about assessment of the airway. We'll talk about maneuvers such as the jaw thrust maneuver, as well as the head tilt and chin lift. We'll talk about suctioning and the different catheters used. We'll talk about the difference between oropharyngeal airway and nasopharyngeal airway. As for the abnormal breath sounds, please refer to the previous video, and let's continue discussion on some respiratory emergencies. How do you assess the patient? First, you look at the scene. Try to assess whether this is a trauma patient or a medical patient. Always start with your ABCs: airway, breathing, and circulation. Assess your patient's age, sex, appearance, pregnant or not. Introduce yourself. Ask your patient, "Hey, what's your name?" Is your patient conscious and responsive? Yes or no? Don't forget your ABCs. If the airway is closed, open it. If there is no breathing, meaning there is apnea, you ventilate. If there is no pulse, you start CPR, which stands for cardiopulmonary resuscitation. Not to be confused with your cytochrome P450 reductase. Vital signs are very important: the pulse, the blood pressure, the respiratory rate, and the temperature. Let the sample acronym guide you. S, signs and symptoms. A, is the patient allergic to anything? M, is the patient on any medications? P, pertinent or present history. L, the last oral intake. And E, the events that caused the episode that we are experiencing. And then you gotta ask yourself, should we wait and treat or should we grab and go? If it's just some minor scratch, wait and treat. If it's a myocardial infarction, load and go. What are the patients that need to go to the hospital right now? Unresponsive with no gag reflex, responsive but cannot follow commands, childbirth with complications, severe pain, severe bleeding, shortness of breath or dyspnea, as well as shock, which is hypoperfusion. When a patient is in shock, do you expect blood pressure to be high or low? The answer is it will be low. The levels of consciousness are many. You start conscious and then you deteriorate, confused, delirious, somnolent, obtunded, stuporous, and then finally comatose. After this, you're toast. Emergency medicine is all about ABC. You gotta take care of the ABC before you worry about anything else: the airway, the breathing, and the circulation. For the pros, you can add DNT. D is for drugs, such as cases of overdose, and T is temperature, whether it's hypothermia or heat stroke. We talked about the airway last time. Let's review. The natural anatomical airway includes nose or mouth. Behind the nose, there is nasopharynx. Behind the mouth, there is oropharynx. The pharynx is made of three parts: nasopharynx, oropharynx, and laryngopharynx. In front of the laryngopharynx, you have the larynx, and under the larynx, there is the trachea. This is the larynx, this is the trachea. You can feel the patient's carotid arteries on both sides of the trachea. Please never, ever, ever examine both carotid arteries simultaneously, or your patient might faint. This is a doofus mistake that should be avoided. Otherwise, I will smite your gluteus maximus, metaphorically speaking. If your patient is conscious and speaking in a normal tone of voice, then the airway is open as of this moment. But this could change 5 seconds from now, and that's why it's always important to reassess. But if your patient's breathing is noisy or gurgly, thou shalt secure the airway now. Please refer to my video called Airway Management to learn about my famous 10 commandments of the airway. If you wish to see more videos like this in the future, please drop a heart emoji in the comments. Is airway the same as breathing? No. Airway is the anatomy. It's your nose, it's your pharynx, it's your larynx, it's your trachea, etc. That's the airway. Airway is the anatomy. But breathing is the physiology, meaning gas exchange. Push the oxygen into your body and eliminate the carbon dioxide from your body. The oxygen is going to flow from your lungs alveoli to the blood. Carbon dioxide is going to flow in the opposite direction. Filling your alveoli with air is called ventilation. Pumping blood from the heart to the lungs is called perfusion. And when oxygen passes from one compartment to the other is called diffusion. Oxygen diffuses this way, carbon dioxide diffuses the other way. Ventilation, just like the cardiac output, is how fast times how strong. How fast? That's the respiratory rate. How many times do you breathe in a minute? How strong is the depth of each breath? So my breathing could be deep and fast, or deep and slow. It could be shallow and fast, or shallow and slow. But hey, medicosis, what are the possible causes of deep, shallow breath? What are you smoking? These are the same causes that lead to a wide, narrow airway. Please do not confuse ventilation with oxygenation. Ventilation is adding air to the alveoli. So when I bring oxygen from the atmosphere to my lungs alveoli, this is called ventilation. But oxygenation is to push that oxygen into the blood and then onto the hemoglobin. That's called oxygenation. Ventilation is how fast and how deep. Oxygenation is oxygen that is freely floating in the arterial blood, and oxygen that is on the hemoglobin. This is the partial pressure of arterial oxygen, and this is the saturation of arterial oxygen. It's called SaO2, it is called percent saturation, it is called O2 sat, it's also known as SpO2. If you want to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. To learn more about oxygenation and the differences among PiO2, FiO2, PATM, PaO2, P-big AO2, SaO2, and PvO2, please refer to the previous video. When oxygen jumps onto the hemoglobin car in your red blood cell, we will say that the hemoglobin is now saturated with oxygen. Oxygen is like the passenger, hemoglobin is like the car. And this car has 4 seats to be occupied by 4 oxygen molecules. We're done with this. Now let's talk about assessment of the airway. Ask yourself, is the patient breathing? Yes or no? Well, what do you mean by is the patient breathing? Is the chest wall moving up and down, up and down, up and down? Do you hear breath sounds? This can be established by many methods. One of them is using your stethoscope onto the patient's chest. Another one is to bring your face close to the patient's nose and mouth and hear and feel the patient's breath. And is there air coming out of your patient? Not from a proctological point of view. That was poorly worded. I apologize. If the answer to these 3 questions is yes, then your patient is breathing. However, just because your patient is breathing doesn't necessarily mean that the patient is breathing adequately. It could be shallow and fast breath, which is not optimal. And that's why measuring the oxygen saturation is very important. What if the answers to these questions were no? Then you gotta open the patient's airway because your patient is not breathing. How should I do this? Are we talking about a trauma case or a non-trauma patient? Trauma patient, start with the jaw thrust maneuver. Please be careful and do not hyperextend the neck because you have no idea how the trauma happened. Maybe the patient fractured his or her neck. So if you hyperextend the neck, you can break the patient's neck and you can damage the spinal cord. This is another doofus mistake that should be avoided. Otherwise, I will massage both of your carotids together, rhetorically speaking. I will never do this because I love you. But if this is a non-trauma patient, then you perform the head tilt and chin lift. So let's talk about these maneuvers. Trauma versus non-trauma. In the trauma case, I'm going to perform the jaw thrust maneuver. You thrust the jaw upwards like this. From the patient's perspective, it's outwards. It is protraction and not retraction. How should I perform the jaw thrust maneuver? First, which jaw are we talking about? We're only talking about the lower jaw, which is the mandible. You cannot thrust the maxilla, you freaking doofus. For the anatomy buffs out there, what are the bones that articulate with the maxilla? Please try to name all of them and comment below. Back to the jaw thrust maneuver. Use both hands as shown in the picture use the index and middle fingers to push the mandible up. Because the patient is lying flat on his back, you are pushing up away from the floor. Why do I do this? Because this pulls the tongue away from the larynx, opening the airway. Then you need to look into the patient's mouth. Whether your patient uses Listerine mouthwash or not is a secondary issue. No one cares. Look into your patient's mouth. Do I find any foreign bodies or foreign objects? If the answer is yes, remove them. Just by doing so, you might have opened the airway. If the patient is not breathing yet, start artificial respiration. But how about non-trauma patients or medical cases, except for trauma? Well, you should lift the chin and push the head back. It is okay to extend the patient's neck if it's a non-trauma patient, provided that your patient does not have an active case of rheumatoid arthritis. If the patient has severe rheumatoid arthritis with articular and extra-articular manifestations, then please do not hyperextend the neck, because patients with rheumatoid arthritis can suffer from atlantoaxial subluxation. The atlas is C1, the axis is C2. These are the first two cervical vertebrae. They are loose and lax in patients with severe active rheumatoid arthritis that is not treated. And then after I lift the chin and push the head back, as you see, what should I do? You put a rolled towel or a rolled blanket under the patient's shoulder, remove any foreign body that you find, and then you're gonna begin suctioning. Why do I suction? To remove water, to remove fluid, to remove excessive saliva. Why should I do this? To avoid aspiration. Because this excessive fluid can end up inhaled by your patient, especially if your patient has lost his consciousness, and all of that gunk can end up in the patient's lung, causing aspiration pneumonia. That's not good. Okay, once you start suctioning, please be careful. Never, ever, 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 ever suction continuously for more than 15 seconds straight. What's the problem for suctioning for more than 15 seconds? The problem is that by suctioning too much, you're removing the oxygen from the patient's airway. And this is a third doofus mistake that should be avoided. Please be careful. I did not say do not suction for more than 15 seconds. I said do not suction for more than 15 seconds at a time. What do I mean by this? Suppose that the patient has too much fluid in the mouth. So you're gonna suction for, let's say, 10 seconds. And then you gotta wait. Listen to your patient's breath. Do something else. And then if the patient needs more suctioning, you're gonna suction again for, let's say, another 10 seconds. But between the first 10 seconds and the next 10 seconds, there is a pause. There is a hiatus where you are not suctioning, so that you do not suction continuously for more than 15 seconds straight. What are the catheters that I can use during suctioning? We have hard tip and we have soft tip. Of course, the hard tip is hard, but the soft tip is flexible. If you want something to enter into the patient's nose like this, it's going to be flexible. If the patient has clenched teeth, it's going to be flexible. If you're cleaning a tracheostomy tube, use a soft, flexible tip, not the hard tip. Next, let's elaborate on suctioning. Types of suctioning. You could suction the mouth, you can suction the nose or the nasopharynx, or you can suction the tracheostomy tube. If you want to suction the mouth and the oropharynx, you can use hard tip or soft tip depending on the circumstances. But if we find clenched teeth, use the soft, not the hard. Next, nasopharynx, use the soft, not the hard. I'm suctioning the tracheostomy tube, use the soft, not the hard. Before you insert your catheter into the tracheostomy tube, you have to lubricate your catheter before insertion. Why is this? Because remember that your mouth has saliva. Your nose has lots of mucous membrane and lots of mucus for lubrication. But the artificial tube does not come with saliva unless the manufacturer has spit in the tube, which is gross. So you're gonna insert your suctioning catheter into the tracheostomy tube. And the tracheostomy tube is inserted into the patient's trachea or trachea. And you keep pushing the suctioning catheter until one of two things happens. A, the patient gags, which means you are irritating the vagus nerve, or the catheter encounters resistance, then you stop. Why are we doing all of this? Because the patient's airway is not open and we try to open it. After you open the airway, you might need an additional adjunct, an auxiliary to the airway. They come in different sizes and shapes. There is a size for adults, a size for pediatrics, etc. Next, oropharyngeal airway versus nasopharyngeal airway. Be very careful with the word airway because you have an airway. This is your natural airway. This is your anatomy. Nose and nasopharynx, or mouth and oropharynx, and then the larynx, the trachea, the lungs. You know the idea. This is the natural airway. And there is artificial airway that is not part of your package. This is something that is man-made. It is manufactured, probably by the same manufacturer who spit in the tube. Artificial airways could be oropharyngeal airway, nasopharyngeal airway, or endotracheal intubation. If you have watched my previous video in this EMS playlist, you will remember this question. In order to choose an oropharyngeal airway, its size should be roughly equal to the distance between blank and blank. And what is the answer to this? Please pause the video and try to answer this yourself. The correct answer for the oropharyngeal airway, well, we call it oropharyngeal for a reason. Oro means what? Mouth. Mouth until the pharynx. Oh, so from the corner of the mouth to the tip of the earlobe is a rough estimate of the measurement of the distance. What do I mean by this? The question was asking about oropharyngeal airway. You're gonna insert the oropharyngeal airway. But which size should you choose? There are big ones and there are small ones and there are medium ones. So which one should you pick? The answer is, it depends on the patient's. To measure what the patient needs, you start your measurement from the corner of the patient's mouth until the earlobe. This is roughly the distance of the patient's oropharyngeal airway. But what if you're going through the nose? If you want to measure the nasopharyngeal airway, you measure it from the tip of the nose until the tip of the ear. This is roughly the size of the nasopharyngeal airway. How do I insert the oropharyngeal airway? There are two methods. Number one, you can insert the oropharyngeal airway in this manner. Not as you see it in the picture, but the opposite. Instead of convex up, you're going to insert it convex down, with the convexity pointing downwards. And then once in the patient's mouth, you rotate 180 degrees until it looks as you see it in the picture. This is one way of doing it. The second way of doing it is to use a tongue depressor to depress the patient's tongue and then insert the oropharyngeal airway as shown in this image without the need to rotate. When should I stop? If your patient gags, it means that you're irritating the vagus nerve. You should stop and try something else with your life. Why am I inserting an oropharyngeal airway? It keeps the tongue away from the posterior larynx, opening the airway of the patient. Because remember, we're doing all of this to take care of the A. What is A? The A is the airway. Remember your ABCs before anything. Airway, breathing, and circulation. As for the nasopharyngeal airway, you're lubricating it because the nose does not have saliva, remember? Yes, it has mucus, but it does not have saliva. Unless the patient has some sort of a congenital anomaly of the palate or something like this where the saliva can enter the nose. After you lubricate your nasopharyngeal airway, you're going to insert it into the patient's nostril. Both? No, pick one. Which nostril should I pick? The larger one, the easier one. Do not complicate things. Unlike the oropharyngeal airway, which must be stopped if the patient started to gag, as for the nasopharyngeal, you can just keep going even if the patient gags. However, when should you stop the insertion of the nasopharyngeal airway? If the patient has facial trauma that affected the maxilla, the mandible, and the surrounding bones, these fractures of the bones of the skull are problematic and you cannot use the nasopharyngeal airway. I don't understand. What's the problem of using nasopharyngeal airway if my patient has skull fractures? Look, my friend, and you shall hear. The patient might be having a fracture in the base of the skull, and your tube could enter through this gap, this fracture, and end up inside the patient's cranial cavity, tickling the patient's brain. And this is doofus mistake number 4 that should be avoided. What is the purpose of the nasopharyngeal airway? You do not insert a nasopharyngeal airway for the lulz. You're doing it to keep the nasopharynx open, to secure the airway. Now let's talk about some emergencies. For more emergencies and for the abnormal breath sounds, please refer to the previous video in this playlist. The title of the video was Respiratory Emergencies. Respiratory distress. What are the signs of respiratory distress? The patient could be having tachypnea or bradypnea, fast respiratory rate or slow respiratory rate. The patient has SOB, which stands for shortness of breath. Because I'm a good guy, I do not curse. The patient might be assuming the tripod position. The patient is trying to breathe, gasping for breath. The patient has difficulty speaking. The patient is very anxious. There is change in the patient's skin tone. Could be pallor or could be bluish discoloration. Decreased oxygen saturation. Delayed, meaning prolonged capillary refill time. Longer than 3 seconds is abnormal. And we have talked about capillary refill time in previous videos. If the patient is using accessory muscles of respiration, such as the sternocleidomastoid muscles, other muscles in the neck like the scalene muscles, abdominal muscles, if you see the patient straining hard in order to breathe, this is a sign of respiratory distress. Mental status abnormalities could happen because of respiratory distress. This is a patient that's not doing well. In neonates, we have other signs in addition to these: nasal flaring, grunting, intercostal retractions between the ribs, and cyanosis or blue color. What causes SOB or shortness of breath or dyspnea? We have respiratory causes or pulmonary causes. We have cardiac causes, metabolic causes, hematological causes, and neuropsychiatric causes. Pulmonary causes include A, B, C, and P. The A is aspiration and acute respiratory distress syndrome. The B is bronchial asthma. The C is COPD or chronic obstructive pulmonary disease, which includes 2 diseases: chronic bronchitis and emphysema. You can learn more about COPD by watching my pulmonology playlist. The P's: pneumothorax, pneumonia, pulmonary edema, pulmonary embolism, pulmonary fibrosis. Cardiac cause of dyspnea. Anything that affects the left side of the heart can cause lung problems, including myocardial infarction on the left side of the heart, cardiac tamponade all around the heart, congestive heart failure, especially of the left side, valvular heart diseases, especially the left-sided valves, such as the mitral valve and the aortic valve. Metabolic causes include metabolic acidosis can lead to dyspnea in response, because acidosis means what? It means buildup of acid in my body. So the lungs will try to respond and compensate by getting rid of the acid from the body. Try to decrease the carbon dioxide that is left inside your body, which means the lungs will try to eliminate your carbon dioxide from your body because carbon dioxide is an acid. How do you do this? By hyperventilating, by breathing more, by breathing faster. Sepsis can lead to shortness of breath. Hematological causes include anemia and methemoglobinemia. Neuropsychiatric causes include anxiety disorders, including panic disorder or panic attack. In the next video, we'll talk about apnea. A means no. Apnea means breathing. So apnea means cessation of breathing. Today's question is here. If an adult is suffering from respiratory compromise, we provide ventilatory support and try to aim for an end tidal carbon dioxide that's usually in the range of blank millimeters of mercury. Is it 5 to 15, 35 to 45, 70 to 80, or 100 to 120? Please pause the video, let me know your answer in the comments. You will find the answer key in a following video in this playlist. If you want to take it to the next level, I have an emergency medicine high yields course on my website medicosisperfectionalis.com. It will teach you about myocardial infarctions, cardiac arrhythmias, strokes, drowning, toxidromes, acute respiratory distress syndrome, acute limb ischemia, and much more. Download it today at medicosisperfectionalis.com. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.